So hi everybody. This is my coworker Janine Corkery. She goes by Jay. So we work in the immunology clinic at the IWK. So we just kind of wanted to do a little bit of an overview of kind of a day in the life of the immunology clinic nurses and what we do over at the IWK. This one.
Oh, that one. Oh, what was that?
Okay, yeah. So we have no disclosures or conflicts of interest to report. And we kind of are sharing the slides. So Jay's going to do some of them and I'm going to do some of them.
These are some of the things we're going to talk about today.
Yeah.
Just some general stuff.
Exactly. So kind of our roles and responsibilities of the immunology clinic nurse, talking a little bit about the subcutaneous immunoglobulin as well as the intravenous immunoglobulin therapies. We do a lot of vaccine boosters in our clinic, so a little bit of topic about that, as well as how we promote health promotion recommendations by our physicians and clinic nurses in our clinic setting. Yeah, thanks.
So we kind of came up with an idea. Actually, I think David gave us the idea of just talking about a day in the life of what we do. But our clinic runs Wednesday and Thursday mornings. Kids come in with their parents, and we are doing height, weight, set of vitals. A lot of the time, we're asking about medications. I would say, in general, anytime you go to a medical appointment, the physicians that are there are going to want to know what meds you're taking, what vitamins, what supplements, any recreational drug use that we're doing. And a lot of the time, when I'm sitting with families and asking about how they've been since their last appointment, if they're a teenager, I always give them the opportunity to talk about their parents' presence. Something that we did in mental health. My whole career has been at IWK. I didn't do a bio kind of thing. But not as long as Karen. I've been only working in immunology for about a year. So I like sitting and talking to the families quite a bit. Dr. DeFalvey is always telling me to hurry up, so I'm always trying to do that. But essentially, we're looking at things like, have you been having a lot of infections, fevers, patterns of fevers, like we talked about before? How have things been since the last appointment? And for me, a lot of the time, wanting to just know how that social stuff a little bit. I think we focus on that a fair amount as nurses, not just the clinical piece, but how are they doing in their life in general? Are they missing a lot of school? Do they have friends? Are they sleeping well? Things like that. I think all of the physicians today have talked about pneumococcal things. And so we do give a lot of boosters in the clinic. Sometimes the doctors will come out of their assessment and write orders right there in the moment if the family has agreed, and then we're collecting popsicles and stickers, juice, snacks, whatever we can to help the child get through what they're getting through. A lot of the time, they're not going to have any topical freezing. We've also done swabbing of ears, noses, urine samples. We see, as you know, in Nova Scotia, we have a lot of refugee families that we're seeing a lot more patients that way. So a lot of the kids are quite sick. So we are doing a lot of those clinical things on the day of the sample of the clinic. If they need blood work done, which is something the physicians decide on, then we've prearranged that for them as well. And we are coordinating with quite a few other clinics. We get referrals from hematology, sometimes from allergy as well, not figuring things out. Chest clinic, respiratory seems to be closely linked with us. And then, we are arranging with our booking clerk all of the follow-up appointments that are coming through. I just wanted to say too, because Dr. Palma was talking so much about genetics, we send out and we coordinate a lot of blood work that has to then go to genetics labs in other parts of this country. We sent some to Cincinnati a couple of weeks ago, as well as to Europe. So a lot of that requires, and I'm doing a lot of that coordination stuff. or lymphocyte function testing, which is just to see how all your various white blood cells are doing.
Yeah, so our next slide, we're just reviewing a little bit about the roles and responsibilities. We do a lot of communication with parents via phone calls, emails. We attend weekly team meetings with our physicians and our nurses, collaborating care for the upcoming week. And like Jay had mentioned, organizing specialized blood work is a big part of the immunology clinic nurse role. We offer family-centered care at the IWK Health Center. We offer spaces. We have a lot of young infants, so we offer safe spaces for breastfeeding moms. We offer interpretive services. As Jay had mentioned, we do have a lot of immigrants, so that's very helpful. And sometimes families are coming from very far away, New Brunswick, PEI, Newfoundland, and maybe it's an extended long stay. So we do have access to nutrition bags that we can offer them out just prior to getting their blood work too. It's kind of fun, yeah. And part of the IWK, which is official now, we offer the Children's Comfort Promise, which basically trying to decrease any pain during a painful procedure. So we try to numb the skin. We offer sugar water to infants receiving vaccines or blood work, breastfeeding, offer comfort positioning and distraction. Those are all part of the Children's Comfort Promise. So we are very engaged in doing that with families. Part of our nursing professional development on a yearly basis, we do like learning modules, webinars, and we've really enjoyed attending a lot of the immunology conferences, obtaining new information on treatments and kind of what's out there for families. So we've really enjoyed that. And then we just do yearly skills recertification on our vaccines, our CPR training. There's a lot of yearly training skills that we do. So that's kind of a nutshell of what we do as a clinic nurse. Yeah. So this one. So just going over a little bit of the SCIG, subcutaneous immunoglobulin therapy. So it's an at-home therapy, as you know, receiving immunoglobulins under the skin in kind of the fatty tissue, usually in the belly or the leg. We do have some previous kids that liked it in the arm. A teenage boy liked it there. We do have two products available, Cuvitru and Hizentra, and they're both equally protective. And two patient support programs now supported through the drug company. And they've been very helpful with the nursing support for teaching, and they're very easy to get a hold of, and been very great with the families, offering lots of teaching experiences. The supplies are covered. There's no cost to the families for the supplies in the home setting. So the patient support program would work with the health insurer for coverage of the supplies. So right now we have about 37 families enrolled between both products. So we have more families enrolled in the home program than we do with the IVIG that they come to the IWK. So it's really great for families and schedules, minimal missed school time, work time. So they really enjoy that. And we're quite proud of a pamphlet that we developed a couple of years ago at the IWK that we can give to families, offering information on administration of the SCIG in the home setting. So it's kind of a nice accomplishment. We've developed that pamphlet. Every child in the program at the IWK that enrolls in the immunoglobulin at home is prescribed an EpiPen because it is made from human plasma and there could be a possibility for a reaction. We've never seen one, as Dr. Derfaldi has said, but it is part of, we could kind of follow suit for Canadian guidelines for an EpiPen at home. And I'm not sure what it's like for an adult at home, but for a child to be receiving the blood product in the home setting, there has to be an adult present during the infusion.
I did want to say too, that the Cuvitru and Hizentra, I know they've been talking a lot about the HyQvia today, Dr. LaCuesta, but that I believe, and there are other people in the room who would know more than us, It's not approved in the pediatric world, I don't believe yet.
Is
It's
that-
18 and
Mhm.
18 and above, but potentially it is that way.
Oops, sorry.
How do we go back, David?
This should be this one here.
Good.
That's
Okay.
yours. Yeah.
I mean, you guys have already heard the doctors talk a lot about subcutaneous immunoglobulins and intravenous immunoglobulins. And right now we have about 13 patients in our medical day unit who come in for IVIG every 4 weeks. You are going to meet one of them today, this afternoon after lunch. Her name is Zainab and she's 7. And I believe she's been getting IVIG since she was about 3.
Mhm.
Yeah, so you'll meet her and her mom. She's lovely. She'll tell you like it is.
Yes.
And we love that. So those children are usually on it every 4 to 6 weeks. The product is quite expensive, as a lot of you guys already know. About $1,000 for 100 mils, maybe more. And last week we gave a 16-year-old, I think, 70 grams, so 700 mils, and that was IV. So lots of bottles and bottles. You know, a 200 ml bottle, you're hanging it up. You know, it's almost a $2,000 product, but it is all covered. Those, although there is a family here that is involved with us, and I think it's great that you guys will all get to talk. And I asked everyone's permission before I put the spotlight on them. But our youngest patient getting IVIG, his parents are here. He's under 1. And they had an interesting experience with the money aspect, just like Ashley has talked about. So I think that would be really interesting to sort of spread around, especially to the physicians who might not be aware of it. But yeah, it's really nice to see patients get the product and be healthier for sure. And you guys can speak to that for sure. Yeah. So we have, even though Karen and I will run the immunology clinic itself, we have a designated nurse, Margaret, who basically runs the infusion area. And I'm laughing because she's so awesome. And we'll also tell you like it is. And she just makes sure that everybody knows when they're coming next. It's just everything runs very smoothly. We use Child Life at the IWK. If you haven't heard of them before, they have the best jobs. They basically are trying to make any medical procedure that a child is going through much easier for them. And so we use them all of the time. They're our favorite people. But IVIG is something that patients can be on for a very long time, and a lot of the patients who are here can attest to that themselves. So, yeah. We're talking about vaccines as well. We do a lot of pneumococcal boosters for sure. Last week, I had to give 3 immunizations in the OR while a child was under general sedation, just using gases really, because that child had been through a stem cell transplant and had severe aversion, needle phobia. So it took months to arrange that through anesthesiology, but she got what she needed, and the anesthesiologist told me she recovered well, and she got caught up with her vaccines. In her case, it wasn't just a booster. She needed a whole bunch of things. And so that was my first time doing that. And I guess that can happen a few times a year for us. Yeah. But we give them in clinic. As Karen said before, the priority is the distraction, trying to keep things as pain-free as possible, which is why popsicles and stickers are magic for us. Like 100%. I don't know what we would do without them, but yeah. I wanted to pop up these slides because honestly, I didn't know who the audience was going to be, and then I found out it was going to be patients mostly, and so I thought, as far as requesting immunization records, I just wanted to put the stuff that Nova Scotia Health has up here. So we will give immunizations in the clinic, but then we are also asking a lot of family doctors to do that kind of stuff as well. Although we did get pushback last week saying, yeah, this family doctor doesn't carry any of those supplies. So that was a very much a surprise because they're the primary caregiver. So we're not sure if we have to connect them with public health, and if public health will give them product, but yeah.
In my own area with NMR and TDAP, where there's been more outbreaks
Yeah.
Okay.
and redistributions, the things that we normally would have, we don't
Oh,
have as much of anymore.
Okay.
We have some, but we don't have as easy access. We will get it back eventually.
Yeah, because
Okay.
it is a lot of the Tdap, IPV, HIV stuff. Yep.
Yes, please. The question I have was, in the case of both my children, they've both been very ill since they've been born. Both my kids are behind in their vaccines because they only do vaccines twice a year where I live, and that always falls when my kids are sick. So in the case of, I run into the same issue with my family doctor, they stock no vaccine supplies whatsoever. What am I supposed to do to get my kids vaccinated? Because basically they have been off and on sick for basically every second month for the last, basically outside of the summer when they're away from other kids. Yeah, I have been struggling to get. My son has more than my daughter. My daughter only has one round because I literally those 2 times every time that I'm able to.
We get told that a lot. Oh, we would have gotten this done. Are you in?
No, I'm technically Nova Scotia. But some of my doctors are in New Brunswick because I'm 4 kilometers from New Brunswick. That's what I'm talking about, public health. So the Amherst Clinic, they only do them it's either twice or I don't know how long. I honestly got tired of calling because my kid's been so sick. I don't know bother scheduling them at this point. But yeah, so I don't.
You're talking for regular vaccines?
I'm talking for everything. Yeah, my daughter. I'm talking regular immunizations. My daughter only has one round of the very very first, actually maybe second, but they wouldn't book because it was in Amherst. Yeah.
This really bothers me because it's that whole system thing, right?
Yeah.
You have.
I'll probably be seeing them soon, so sometimes whenever. Yeah, I circulated an email already. But what I was going to say is that sometimes whenever I've had problems with immunizations outside of the, when we request someone to be immunized, I usually provide a letter of some sort, and I have received calls from public health, like New Brunswick, not usually Nova Scotia, more New Brunswick. I wasn't aware of this as well, but anyways, I think once you guys are on our radar, we're happy to be what I always say to parents as well whenever I see them, but that's me. I don't know if anyone does. It's that they should be, if this doesn't happen, like if the immunization doesn't happen, just let us know, and we're happy to troubleshoot however we can. But that being said, I'd like to see how they are baseline, and then we'll boost them with whatever is needed.
There are a lot of needle books for required for patients, whether it's an immunization or blood work. Because the immunologists want to know what the blood work is before the vaccine. A lot of the time, especially if it's a new patient to them and they don't know, don't have any answers for things like their level of immunoglobulins. Then you give a vaccination, and then the child needs blood work 4 to 6 weeks after that. So that can be challenging. That's why a lot of the time, patients will be booked for a day and will have cancellations because they didn't get their blood work done or they didn't get their vaccines done. So, are we on this one already?
Yeah. I can jump
Okay.
in there.
Let's hear
Yeah, I
it for
guess.
sure.
And
How
Dr.
did we skip that one?
Oh, we had that
Text report, sorry. If people online can't hear you.
one. Oh, yeah.
Oh, really?
Here.
Already? I think before we move to that, I just wanted to.
Did the Zoom meeting, they're still on.
I'm not very tech savvy at all either,
Just
so.
talk about the number of another platelet disorder, for example. And no, like, they have like a little buzzy.
We have a buzzy now.
And they have like, if you get so many pokes, and your finger grab or whatever, you get a little boy or something.
Oh, that's a good
I
idea.
was like, is there anything like that?
Like a coffee card.
Yeah,
You get so many.
Yeah, exactly.
That's a really good idea.
Like, I think, like,
Free parking.
yeah,
I wish.
It's nothing major, but it's something that they.
Thank you for that idea. That's a really good idea, actually.
It's the PSA.
Okay.
Can you guys just talk for a second? See?
Testing, testing. Can you guys hear okay? Online? I know. I just didn't finish my vaccine stuff. I just wanted to point that out. Sorry. And then. Yeah, exactly. Test, test, test. Good. I think we want to go back a couple more. One before that as well. Hello? Anyone, can they hear okay? Okay, great, thanks. Pick one. That's fun.
All right, we're back.
We're back.
So,
We'll just
So,
finish up
so
that
yeah,
slide,
this
yeah.
slide I just wanted to put up for anyone because the Vax record Nova Scotia is new in Nova Scotia. You go on there, you need a health card. Essentially, it's a Nova Scotia health account. And it would show like, because I'm older and all my vaccines are like from the 70s or whatever and 80s, it just showed the COVID and flu things and my tetanus that I got recently. But I can download all my own information on there. And so for parents who prefer digital stuff, you can put all your kids' vaccines and have them all on there. And then I just put some COVID stuff up there because, of course, as nurses, we do promote everyone getting their flu shot, the flu season, and their COVID shot. And I think but spring COVID shots were being offered right up until yesterday, I believe, out in the community. So, and then of course, there are public health mobile units every once in a while providing those sorts of things. You just have to keep an eye on the public health website in Nova Scotia. So,
just so slight technical thing, just we're on Zoom, but the slides.
that's okay. We're
Okay. I think we have one or two.
You don't have your screen shared?
That's the only thing. Alright, sorry. Can you see?
Oh, I get this one. This is one.
I pushed hide.
Yeah, you hit it up, you hit it.
Right, double tapping where it's down the right. Then up arrow. Oh, yeah, that's it. Thank you. Awesome, thank you.
so now people at home are seeing this for the first time. On and off. Okay.
Okay, so
So I'm not sure if that's enough time for people to kind of take a picture or see some of the information on there, but mostly it's the vaccine record Nova Scotia I wanted to pass along to those who are here.
I know Dr. LaQuesta talked a little bit about RSV prevention, so I just wanted to mention a little bit for our immune deficient patient population at Yada UK. So RSV causes major cause of hospitalization and usually infects all young children by age 3. Very contagious. It can present as a mild illness, like a flu, like a cold-like illness, or further like a serious illness, which infants and young children could be coming to the hospital with pneumonia or bronchiolitis. So our immune deficient infants and young children with low lymphocyte counts would qualify either before bone marrow transplant or after to receive the RSV prevention injections during the winter months, where they're most vulnerable for a serious RSV infection. So the goal of the RSV prevention injections once a month for 5 months during the winter months is to prevent a serious hospitalization where that infant might have to go to the pediatric intensive care unit to receive ventilator or fluids or oxygen. So the best prevention of RSV is hand washing, as well as any other respiratory viruses during the cold and flu season. So we really monitor and make sure that the infants that are most vulnerable are protected. And our last official slide, what we had mentioned, one of our objectives is just talking about health promotion recommendations. So like Jay had mentioned, like we do the vaccine history when they come to the clinic, make sure that they're kind of up to date on all their childhood baby vaccines and vaccines prior to the school entry. We promote the annual flu and the COVID-19 vaccines by our immunology physicians as well, and avoiding sick contacts. So if you have relatives that are sick, it's best for our immune deficient patients to kind of avoid large gatherings when there could be spread of infection. There is like prior to a dental procedure, there is a protocol at the IWK prior to dental procedures to receive an antibiotic prophylaxis. So that's kind of reviewed prior to the child going to get a dental procedure at the IWK. We promote healthy eating habits.
Yeah.
Jay was really good at obtaining this, getting out and, being active, getting off the
You guys
screen
see
time.
this around the city? These are free programs for community health teams as part of public health. And so I've got a pile of these for anyone who wants to check them out. I think they put them out 2 to 3 times a year. Just those last 3 bullets there, eating well, plenty of rest, have fun and exercise. It's always those 3 that it's like the basis of everything that is always sometimes the hardest to do. And I would say on one side, we have a lot of choice, but if you look at access, some of us don't have a lot of choice. So, and another thing I just wanted to add after listening to all the other talks today, but arriving today and seeing the parents of our youngest IVIG kid, and then a face from high school that I had to ask about, and learning that Carrie and Tim are the parents of a 21-year-old son who was diagnosed when he was 15 by one of our doctors who's still with us, I think. And I asked their permission if I could just put this out to the room, which is they're, as parents, struggling with their son kind of accepting what he's living with and living with a lot of symptoms and having a needle phobia and not wanting to try SCIG or IVIG, but a consistent like full body stuff going on, like outside on his skin, itchy and rashy, and then a chronic sort of productive sounding cough. And I think it's making me realize that, as Dr. Palma already said, there is a lot more that we could do when kids are transitioning from peds to adults in making sure that they still feel connected, but then I think also connecting parents to parents at all ages, because even now you're saying you would like some connection to parents, and I think it's important for parents to be able to sort of have somebody there, just like anyone. If you're experiencing something, there's not a whole lot you have to explain. You can relate to each other in a certain way, and so I think if there are people in the room who are physicians or volunteers or staff or other patients who have some advice for some of the parents that are here, I think it would be welcomed. So. Oh, yeah. Here, Ashley, here, what, say that again in the mic. There you go.
I am both a parent and a patient, so I was quite young. So any parent is more than welcome to reach out by email or by phone. I'll certainly give it to you guys. Feel free to circulate it. You can call me anytime. I'm always frequently travel all across the province, so I enjoy meeting up with anyone anytime. So anytime.
So I just wanted to say that regarding having fun and fresh air piece, sometimes there, like I said a little bit, but I was running out of time. It's I mean, if there's a severe problem, the bubbling is necessary, but if there's not, and sometimes there is the misconception that, you know, immune deficient means bubbled or isolated. And I actually had to struggle with this during the COVID pandemic because children were actually our patients were doing better, if you will, because they were so shielded in a way. But when it was time to go back to the normal life, they were very, very scared about it. I actually had a couple of new patients who had a very bad experience before getting supplemented with SCIG. And they were wondering if school could be resumed or activities. And the truth is, once they were in SCIG and they were doing really well, the parents who were extremely bright and very, very caring were fearful of, well, going back to this round of ER visits, frequent hospitalizations and stuff like that. And in the end, what I said was like, I think we also need to prioritize their mental health, and so it's a delicate balance, you know. And I do understand the fear, but at the same time, we cannot have them staying at home all the time. And so I think it's well, that taught me a lot about, like, you know, like, yes, we need to protect them, but also there needs to be a component of like having a normal child's life. And they changed dramatically in terms of, even when I saw them in person, they were very much happier, I would say. So that's kind of my experience.
We're talking about Kelly County experience and very when you're a teenager and you understand versus being.
I was always sick, so it took a while to get the actual the person who actually diagnosed me from Toronto and via Halifax. So it took a while to be official. I don't know my official. I think I would have been technically 18, but it was a 5-year process to get there. But I had been basically in and out of the hospital there was a general theory that I had an immune issue, and I was on antibiotics constantly too, because I had in my right.
I got you.
Okay, good. I had chronically low IgG and high IgA and low IgM from basically birth, and it was tested all along. But to get in my generation where I'm from, they couldn't get me to an immunologist. There just wasn't one, and then I moved away after school. So.
Yeah, I just wonder if you could give them these guys some insight. I'm just trying to connect people.
I would be called that because I did struggle too, and I'll be honest, I for a long time before I got too sick. And once you get down that train of, I moved away when I was 16 to finish high school because I was just so sick and ill with it, and then eventually moved to Newfoundland, and it caught up with me, in which I had 4 back-to-back rounds of pneumonia, and that's the answer. But yeah, I'd be more than happy to.
I thought maybe I'll just for a second. But it was very obvious. that
Mike told me to read about it on the internet because I find more information there than Patrick.
But eventually, the acceptance.
He does. Oh, trust me, I've gone to Vegas five times. Trust me, I.
Ju-
So,
Oops.
my son, he wasn't diagnosed until he was 15, but he was born sick. He was born very rashy, and always had infections, and we were always going to the doctor and duty doctors in between that. And he wasn't bothered by anything, and that's what was so alarming, that he was used to it. He was used to be, that was just his status quo. And I remember times taking him to soccer, take off the socks, and he looked like his feet were burnt, like third-degree burns because of the rashes, but he would just tolerate it, and he'd be running around the field like nothing. So it wasn't until, it was, I did my best to stay on top of everything. And by the time he was 15, he had 10 pages of antibiotics that he had been on from when we got the printout from Shoppers. And I finally went to the family doctor and said, he needs to see someone. He needs to go to a dermatologist, because I thought it was some kind of, and so it was actually Dr. Ariel Burns that we were in her office for 5 minutes, and she said, okay, he's got a bacterial infection. He's got candida, he's got a fungal infection in his nails. His nails were green. And she's like, I actually have never seen a patient with this, but I think he's got Job syndrome. I read it in my books. I studied it in dermatology. And then that's what expedited the process to get to immunology. And so then the IWK was phenomenal in his care and treatment and the checks every time that he went in. But then the transition to the adult system has been rough. And so now, because he wasn't diagnosed until he was 15, he is that sort of invincible, doesn't think, he's always lived with this. So why is it such a big deal now? And it's hard as a parent to,
Because I mean, I lived it, so I told
Yeah.
him, I see, and now that I'm a parent of two young kids.
right,
I totally get it, because I was your kid, and now
Right.
I'm 38, and I see the other side of it, and it is hard, and it's not gonna hit him right now, but in a couple of years from now, that's what, and it derailed my entire, when I was in secondary. I was so sick by the time I went on IVIG. I had to cycle azithromycin, 5 days on, 2 days off for a whole year. Even on IVIG, once I finally said, it went far.
Mm.
Just the way you describe it. Oh, I've
been there, done
and
that.
David moved off for support.
Thank you. I appreciate that. Yeah, it's tough as a mom to watch
It is hard.
that and not be able to kind of force him to go and get the treatments that he needs, and for him to downplay everything. And so it's always a constant worry.
I wonder if you help with talking to someone that, you know,
Yeah.
just, knowing someone that, because I do get, you just want to live your life.
Yeah,
You don't
yeah.
want to be sick, and you don't want to feel different.
Yeah.
Want to jump as high as fast as they can. The thing is, the treatment can't, but it does, it's just gonna get sicker. Or extra short.
One of the other groups, I just started being involved with, they had a quote, I thought it was so perfect. It's like, welcome to the group that you never hoped to be a part of, but you sure are glad there's other people.
Right.
Well, let's repeat that with people online. Welcome to the group that you never wanted to be a part of, sure are glad there's other people here.
Randomly, when did genetics think you come? I know, I actually asked my mom to see if I ever had genetics.
So, I mean, there. Hello. We had to be very, very obsessive with the manifestations as you were mentioning, like atopy, fungal infection, like very, very thorough and choose one over the 400 at the time. So we could choose that candidate gene and sequence that, at least on their setting I was working at. Since I'd say since the late 2010s or so, genetics has been available. I have to say though that in children, it's the most we're very eager to have the genetic diagnosis, and I have to say that I think some adult physicians don't have access to it, so that they're not approved to get it, whereas we are. So in fact, I sometimes, and I've done this before, whenever I see a child and the parent tells me I was the same, I usually bypass the system a little bit and do blood work on both, because to me it's information as well. Yeah. So one thing I wanted to say aside from that is that first we're trying to get a lot. I like that's why I think the warning signs, even though they're not perfect, they still create awareness in the general population. But we're also trying to reach out more to the other specialties, such as derm or ID or hematology. Like we're because they're the surveillance system of the patients who have not so common manifestation, and if we don't hear about them, we can't help. So it shouldn't be that long, and we're that's why awareness is so important. But you shouldn't need to have fungi in like your nails being green, and that's why I was also so shocked to see this patient who had candidiasis in his mouth for 8 years. Like, it's quite late. So anyway, but we're working on that.
So, Brad's got a question. I'm not sure which one works.
Just I guess a real quick question for you guys. Is there a transition period for peds to adults at the IWK? Like, is there, like nowadays, well, your 18-year-olds aren't out living their lives in their world. They're living with you till they're like 20, 30. So, I mean, just because they turn 18, they don't become all of a sudden adults. And so if you've got a family where there's people who are in their, younger ones, you continue to see them as a family and then eventually move them. Because I was going to ask both of you at the same time, because I know some centers it's a hard stop, and like you can have a bunch of 12-year-olds, 15-year-olds, and then the 18-year-old goes by themselves. And if so, is there a transition, or is it just like push the bird out of the nest?
No, it's
Yeah.
So getting them prepared, calling in their own scripts. So we have a whole nice ready on preparing. And then each time they come to the clinic, we give them another one like every 6 months. But generally after they finish high school, they complete high school, then if it's a straightforward, not complicated immunology, then normally they're transitioning to healthcare. And we have a whole transfer of care report that goes over to the new immunology physician. But if they're complicated, I know we still have at the IWK a 21-year-old.
I was gonna, is that the
Yeah.
equivalent of anything? I was qualified.
So I was going to ask if it's like provincial as well as like a rule, like, sorry, you can't come to the IWK anymore.
So the problem is we can keep them in terms of seeing them as outpatient on a clinic, but the ER or the admission would be tricky after 18.
Okay.
And so we do try to do it, but I'd be happy actually, because it is something that we have to improve, because for some reason, well, this happens with a lot of chronic illnesses also, not just immune problems. It's also very well known that, for example, patients who have HIV in the pediatric setting, when they go back to adult, when they go to the adult care, since we're always like, and this may sound funny, but we're like, it would be good to take your medication. It would be good to, do this and do that. And I think they like that because we're always aware of it, whereas it might be different in an adult setting if you have an adult. And if you have any tools any advice for us on how to route that transition, I'd be happy to have that, because we could certainly incorporate them, and we may have some ideas, but it's always good to see the recipient kind of. And I am a little bit guilty on holding on to them a little bit more, particularly when there's something that still needs troubleshooting. And I personally do a summary letter when it's of all how the patient is now, or I try, but there's always room for improvement. And I try to keep them, but sometimes they need to go to the adults as well.
People keep asking questions because lunch hasn't arrived yet. That's great. Just to quickly say, it's just a small thing that we do as a patient organisation, but once a month. It's an online immunodeficiency families. It's a Zoom get together. I can't remember the date of the next one, but when you sign up as a member, you'll get information about when that's coming up and how to join. And then we have an Atlantic Community Connect group, which is run by Angela. You know, those are two ways of coming together. And we've been talking about like what do we need to do more of in terms of trying to get you know, kids talking to one another, teenagers. Like we always look down south to the IDF USA because they do so much, but they are a very different organization. But what we have done is we've had a nurse reach out to us to say we have a patient who has a teenage son. They've never met someone like themselves before. We heard so-and-so has one. So we try and join the dots that way. And yeah, I don't know.
I don't want to.
No, don't. I think that's pretty much it from me. Yeah.
So I want to say that background from as well. Sometimes some sponsors to the pharma companies will organize like a day of like where there's like fun activities for children and stuff like that. So there's also possibilities of doing with the proper care, but with the proper measures, something for the children as well. Aside from the parents meeting, just throwing that out there.
And it's open to any child who has a cancer diagnosis and their siblings. I want to stress how important this is for siblings as well, because they're also living in this house. I don't know if there's anything that could be developed that's similar. Oh, look, you can do that.
I just can't.
So a couple camps, I mean, Camp Brigadoon does run camps for a number of different chronic illnesses, and so you can go on their website for people that have illnesses themselves. Camp Triumph is a camp for siblings of children with a chronic illness or living in a family with anyone with chronic illness. So mom, dad, anybody that lives in the home or they would spend a lot of time with. And it's a camp designed specifically for siblings of or children that have a secondhand experience with chronic illness. It's in PEI in Kensington, I believe, but a beautiful camp as well, all inside Brigadoon.
Awesome. Thank you for that. Yeah. Any other questions before we break for lunch? Yay, Zainab. I'm going to bring the.
I have zero control over what's going to come out of her mouth.
Yeah.
All the tries and advances. Some of you know her.
You guys still go to immunology?
Yeah. Thank you so much.
Work with that.